Thank you, Stephanie, and thank you for the Scleroderma Foundation and the supporting staff for organizing this event. Thank you for the blue necklace. I do qualify for a blue necklace as I started doing this conference in the year 2000, and I've been doing it every year since then, and I hope to continue doing it as long as I can. Today I will be discussing an overview of scleroderma and the treatment options. So I will focus on the treatment options based on the organ involvement. So I tried to cover almost most organ involvements with the exception of the gastrointestinal involvement, because our expert Dr. Brown will discuss the gastrointestinal involvement. My research focus is mostly sarcoidosis with progressive interstitial lung disease and most of the connective tissue diseases that affect the lung. I still see a lot of scleroderma patients, but I haven't been doing much clinical trials in scleroderma. Hopefully we will start soon in the next year or two, being a site for clinical trials for scleroderma at the University of Illinois. This is my disclosure. I have nothing to disclose. I will discuss, though, non-FDA approved therapies for scleroderma. What is a scleroderma? It is a multi-system disorder, the etiology of which is unknown. It's characterized by a thickening of the skin caused by accumulation of connective tissue, and it's characterized by involvement of the internal organs. The word scleroderma comes from Greek, meaning hard skin. Early symptoms of the disease often include cold hands, or what we refer to as Raynaud's, tightening of the skin, changes in the facial features, heartburn, shortness of breath, and fatigue. Patient awareness about scleroderma is crucial. You have to be your own advocate. You have to be aware of the research around you. And it is a disease where there are limited randomized controlled trials that involve large number of patients. Thus, making a clinical decision is hard. So you need to be aware of the clinical trials, the centers around you, and what would change your quality of life and what would serve you best. How do we classify the disease? How would you know what type of scleroderma you have? The disease can be systemic or limited. It can be localized, and there are many disorders that may mimic scleroderma that we refer to them as scleroderma mimics. So the word scleroderma may be confusing because it may refer to different subsets of the disease. So let's try to understand how do we make distinction between the different types of scleroderma. Localized scleroderma describes the subset of patients who have involvement of the skin and thickening of the skin distal to the elbows and distal to the knees, meaning you get skin involvement from the elbows down to the hands and from the knees down to the feet. So you won't get skin thickening involving your chest or your abdomen. And this form of the disease is characterized by Raynaud's, digital ulcers, and high risk of developing pulmonary hypertension. When we talk about diffuse disease or systemic sclerosis, this is the subset of the disease where the skin thickening or the skin involvement goes beyond the distal part of the elbows. It can spread to the proximal part of the arms. It can involve the skin of the chest, and the skin of the abdomen. Localized scleroderma. So localized scleroderma can be, I'm sorry, I think what I mentioned about localized, I meant the limited scleroderma. Let me focus on this screen because is there a way to put the light a little bit lower here so the screen is more... Thank you. That's great. Thank you.
Valid with the video and
So let me go back to explaining this because I did not see this. This is the localized. Okay, we start with scleroderma. So you have the systemic sclerosis and you have the localized scleroderma. Today I will not talk about localized scleroderma. Localized scleroderma could be morphea or linear scleroderma. And that's a type of scleroderma where you may get localized skin thickening. And that skin thickening can be in the scalp, where it causes distortion of the way the face looks. Or it can be in the skin in the abdomen or other parts of the body. But that type of scleroderma, there are rarely associated systemic symptoms. And it is very different than systemic sclerosis. So it's not our topic today. Today we will focus on systemic sclerosis. Systemic sclerosis can be limited, diffuse, or what we call scleroderma, siniscleroderma. Scleroderma siniscleroderma is the type of scleroderma where the patient may present with pulmonary hypertension or interstitial lung disease without features of skin thickening or other features that may guide us to the diagnosis based on Raynaud's or skin involvement. Simply, they may present with progressive interstitial lung disease or progressive pulmonary hypertension. As time goes by, they may show other features of involvement outside this internal organ involvement. The diffuse scleroderma is the type of scleroderma that involves the thickening of the skin distal to the elbows, proximal to the elbows. Almost every part of the body can be involved with the skin thickening. That is the diffuse form of scleroderma. That form is associated with progressive lung fibrosis, needing for oxygen, and at times needing for lung transplantation. The limited scleroderma is the form I described where you have thickening just distal to the elbows. So you get the skin thickening distal to the elbows, distal to the knees, no involvement of the chest and the abdomen. This is the form that is associated with high risk of pulmonary hypertension and commonly Raynaud's and digital ulcers. Again, to emphasize that point, this is the limited and this is the diffuse. And the diffuse meaning the skin thickening can be anywhere. The limited, it does not involve the abdominal, so those does not involve the abdominal area. The diffuse, any part of the skin can be involved. The peak age is 35 to 64, so this is a disease that affects young people. And women are most commonly affected with this disease, more than men. But when a man develops scleroderma, then the prognosis is worse. The incidence is 20 per million per year in the United States, and the prevalence is 240 per million. Again, emphasizing the importance of recognizing those two forms, the limited, where the skin thickening is distal to the elbows, not involving the trunk, and the diffuse, the skin thickening is proximal to the elbows. Why do I focus on this? Because you need to check your body, and if you notice these areas involved in the chest and an abdomen, that requires immediate attention, because those are the patients who would require to start treatment quickly, because that may indicate internal organ involvement. What are some of the other differences between limited and diffuse? Raynaud's occurs in both, whether you have the limited form or the diffuse form. The vascular features, which we mean telangiectasias, dilated blood vessels, digital ulcers and pulmonary hypertension is more common in the limited form. The limited form in the past used to be referred to as CREST syndrome. The fibrosis is more common in the diffuse disease, meaning lung fibrosis. Heartburn, GERD, gastroesophageal reflux disease, is prominent in both. Interstitial lung disease occurs in both, but is more severe in the diffuse form, and the limited form has a better outcome, except if there is severe pulmonary hypertension. What are some of the other manifestations of scleroderma? We talked about Raynaud's as a manifestation, skin involvement, gastrointestinal involvement, heart involvement, lung involvement, kidney involvement, systemic symptoms, which can be devastating to patients, from fatigue to inability to do things, to sometimes feeling that you're 100 years old, you wake up in the morning, you feel you can't do much, and even if you force yourself to do an activity, after working for an hour or two, you feel you have to pay for that. You have to go and sleep for 2 hours or rest one day. I mean, I hear patients tell me that we go shopping, and after we come home, we have to rest for 2 days to be able to recover. So those are some of the associated systemic manifestations, in addition to the arthritis, muscle involvement, and neuropathy. Why it is important to list these symptoms? Because if scleroderma, if you are given the diagnosis of scleroderma, you want to ask yourself, do I have heart involvement? Do I have involvement of my gastrointestinal system? Do I have arthritis related to scleroderma? And if so, how do I manage the symptoms, and what is the best course of treatment? Those are pictures to show you the highlights of what we mean by limited disease, or formerly known as CREST syndrome. You see the Raynaud's, you see the telangiectasias, and you see the calcinosis. This is the swelling in the digits with calcium deposits, and sometimes these may open, white chalky material may come out. It's important to exclude gout, because gout may occur in patients with scleroderma and may be confused with calcinosis. I'm sorry to say that calcinosis is one of the features of scleroderma. Despite all the advancement in scleroderma care, we haven't made much improvement in the outcome of calcinosis. There are no new therapies. So basically, you may try different things, but short of just surgical removal of the calcium deposits and consider some investigational therapy, there hasn't been a single agent that will cure calcinosis. The therapies that are available are extremely toxic and are not worth it trying until we have a clinical trial. It's important that you see an experienced hand surgeon that has experience with scleroderma before you decide removal of these calcium deposits. Some of the medications has been used, like bisphosphonates, the medication you use to treat osteoporosis. They may be helpful in some cases with calcinosis. However, keep in mind that those bisphosphonates mostly given by mouth, and may be difficult to take them if you have esophageal involvement. So in scleroderma patients, it's preferred to give these medications through the IV. If you have osteoporosis or low bone density and calcinosis, best to take these medications through the IV to avoid the gastrointestinal risk. This is the systemic disease, tend to be worse in African American patients. You see how the skin tightening, change in facial features, and some skin changes that we refer to as salt and pepper appearance. Sometimes there is skin color changes, especially in the upper chest, in addition to the Raynaud's. What do we mean by skin score? When you go to see your doctor and there is a skin thickening, your doctor who is specialized in scleroderma will be doing something called skin score. There are different ways of judging the thickening of the skin. One way is you have an experienced rheumatologist with expertise in scleroderma, checking different parts of the skin and giving a score to every part that they check. So the way we do it, we touch the skin. The skin should be elastic. You should be able to move the skin. But in scleroderma patients, sometimes the skin is very tight. So we give it a score, and we touch different parts of the body, and we end up with a number that we refer to as a skin score. Why this is important? Because if you have a high skin score, this is a bad sign, in a way meaning that you need to start treatment early, and you will use this as your baseline when you visit your physician later to see if your skin score has decreased and responded to treatment. And some of the guidelines that has been put out there to treat scleroderma, especially with skin involvement, depend on the skin score. How do we diagnose a scleroderma? Again, there are guidelines to diagnose scleroderma. So what happens when we put these guidelines, because I've been involved in actually many guidelines, but mostly related to sarcoidosis, but it's the same principle. Experts will meet in a room, we'll put an agenda, and we say, based on the published literature, what are the best practices based on the science, based on the evidence? If we look at all the research published, and we try to sum it up, and come up with guidelines that we put together. Let's say we want to come up with guidelines for Raynaud's. We will pull all the studies published about Raynaud's from 1960 until now. And we will grade these studies based on their importance. Were they randomized controlled trials? Were they good quality studies or not? We look at the conclusions of these studies, and then we'll come up with a summary. What would be best to treat Raynaud's? If it's mild, it is severe, if it's associated with digital ulcers. So the guidelines coming from the American College of Rheumatology and the European League Against Rheumatism to diagnose and treat scleroderma. For the diagnosis, those guidelines are helpful when you do clinical trials. But if you are a patient coming to my clinic with Raynaud's and digital ulcers and some autoantibodies, you may not qualify for all these guidelines, for all these recommendations how to make the diagnosis. We will not follow every single thing published, because this is meant to be for clinical trials. If we want to make sure that every patient qualifies by every criteria, we may miss patients, and our goal is to diagnose the disease early. So those are helpful for researchers, helpful for you. I have them in your handouts, just to see how many criteria you may have out of the criteria listed for the diagnosis. So you go see your physician, the diagnosis is made, you tell your physician the symptoms, so you're given the diagnosis, clinical diagnosis of scleroderma. Right there at that visit, your physician will be able to decide whether this is limited, diffuse, whether it's localized, or whether it's a scleroderma mimic, whether it's another disease called eosinophilic fasciitis, or whether it's a disease called nephrogenic systemic fibrosis, or whether it is another disease of skin thickening. Those need to be excluded before you make the diagnosis of scleroderma. Then you will be asked to do a blood test. And some of the blood tests may be $2,000, $3,000. There are changes in the way we check those autoantibodies. One thing to keep in mind, different labs do these antibodies different. So you may go check your anti-nuclear antibody at Quest, or at a major academic center, or at another lab, and get different results. Don't panic if you see different results or different values, okay? The number per se may not mean much. So if your anti-nuclear antibody is say 1 to 160, and you go check it in 2 months and it's 1 to 640, that may not mean that you're getting worse. So we treat the patient, we do not treat the numbers. This is crucial, to look at the numbers with a grain of salt and ask yourself where the test was done, what is the importance of the test, before you panic about the test. There are newer techniques where you may be able to get a panel of all these tests in one blood test through a finger prick. I think that is an evolving research. And I'm excited about other research going on, where through a finger prick, if you are a patient with scleroderma taking methotrexate, or taking Plaquenil, or taking Celsip, you'll be able to have your blood level of these medications checked. Because sometimes we give these medications, we don't know if we're giving the right dose or not. So this is a list of some of the antibodies that your physicians may check. Suffice it to say, remember two antibodies. The SCL70, which is the topoisomerase, and that is the hallmark of systemic diffuse disease, and the anti-centromere antibody, which is the pattern of your anti-nuclear antibody, and that is the hallmark of the limited scleroderma. Okay, so those are the two important antibodies. The other antibodies are important when we think about scleroderma, renal crisis, and other forms of scleroderma, but those two antibodies are important to remember. RNA polymerase antibody is important because if in patients who have kidney disease and diffuse skin disease, they may have this antibody. Not all the centers will check all these antibodies, okay? What happens to the skin over time? I was trained by Dr. Michael Ellman, who started the Scleroderma Clinic at University of Chicago. And I would say in the year 2000, he taught me a lesson. He said, if you discover and diagnose a scleroderma early, regardless which organ is involved, you got to treat early. And it doesn't matter which medicine you use, as long as you know how to follow the toxicity and you pick the right medicine for the right patient. And I think that sum it all, despite all the advanced in research, I find this statement to be the most useful. Skin over time may get softer by itself, but oftentimes, if the skin score is high, we do need to give medications to help with the skin. So over time, after the 2 years of diagnosis, the skin involvement may get worse. That's why when we always say treat early, we mean the first 2 years of the disease, because that's when you expect the skin score to increase and most of the complications to happen. Heart involvement, I will not focus on the details, but it's important for every scleroderma patient to be evaluated for cardiac involvement, meaning whether it is involvement of the walling of the heart, having fluid around the heart, whether it is arrhythmias or palpitations or irregular heartbeats, whether it is pulmonary hypertension. Most important, I would say heart attacks, coronary artery disease. It is important to make sure you are not at risk of heart attacks, which there is an increased risk of peripheral vascular disease and microvascular disease in scleroderma patients. This is an example of Raynaud's, and when we see this, nowadays we admit to the hospital and we start Iloprost IV. So this is one of the new changes based on the guidelines. You don't wait too long. So the guidelines suggest that if you have mild Raynaud's, you start calcium channel blockers. This is the first recommendation, is to start with a calcium channel blocker, which is something like Norvasc. Okay, but if it's severe, you may want to admit to the hospital and give what we call Iloprost IV. Digital ulcers. Some of the most painful manifestations of the disease. Patients who have digital ulcers have very poor quality of life. They can't sometimes wash their face or comb their hair. And in terms of digital ulcer treatment, wound care is crucial. According to the recent guidelines, bosentan is recommended. I was fortunate to be one of the investigators in the bosentan clinical trial. So it is an oral medication that may decrease the recurrence of digital ulcers. However, do not start it without checking with your cardiologist, especially if there is a concern about pulmonary hypertension. There are other medications that has been used to treat digital ulcers, including phosphodiesterase inhibitors. Example of that is Viagra. So Viagra is a phosphodiesterase inhibitor. So when we talk about digital ulcers, wound care, bosentan, which is endothelial antagonist, and phosphodiesterase inhibitors, plus other medications that will improve blood flow. Lung involvement. It can be severe interstitial lung disease, where the lung parenchyma itself is involved, or it could be the pulmonary hypertension. Those are the two main manifestations of lung involvement. So every patient with limited scleroderma need to be screened for pulmonary hypertension. And every patient who have diffuse disease need to be screened for interstitial lung involvement. So the least, you would need a pulmonary function test as a baseline and an echocardiography for the heart to check for heart involvement. And we suggest as well getting a blood test called the BNP, the natriuretic peptide. This may be helpful in identifying early cases of pulmonary hypertension. Let me focus on the treatment before I start answering your questions. Let me give you an update about what has changed in the treatment over the last year. When we talk about the treatment, most physicians will follow the guidelines. However, the guidelines are not set in stone. We have to focus on the organ involvement and pick the organ that need to be treated. So early diagnosis is important, as well as intervening early with treatment. So I will go back to this slide. Actually, no. Let's focus on a few of the newer treatments. We've discussed before in the past few years multiple treatment options for scleroderma. So we have the treatment for the skin. Over the last year, the study about stem cell transplantation has been published. The results of the Scott study that started a few years ago has been published in one of our best journals called New England Journal of Medicine. And the Scott study compared the use of cyclophosphamide versus a stem cell transplantation to see if that will make a difference in the mortality and the long-term outcome in patients with diffuse disease, okay? So I listed it here among the options to treat the skin, but the medications that you would consider to treat the skin will be methotrexate is one of my favorite drugs to start if there are no side effects or no contraindications, injectable methotrexate. You would consider mycophenolate, cyclophosphamide for severe cases where there is lung involvement. You would consider stem cell transplantation if there is severe involvement. So mild involvement, you go with mild medications. Severe involvement, you go with big gun therapy. The other medication I listed there is limited data about those medications. But if you have early skin disease, no inner organ involvement, methotrexate or low-dose prednisone will help, or low-dose mycophenolate. If you have diffuse disease, progressive skin involvement, worsening of lung function over time, where you are told the mortality rate is high, then the two options are the stem cell transplantation, cyclophosphamide, or mycophenolate. Which is better? Nobody knows, because we don't have long-term outcome data. Here is what I presented to you about the skin score, where based on the skin score, guidelines are being formulated. I wanted to mention that in your handout, so you have a reference to it. But again, I would defer to your expert scleroderma doctor who treats you to discuss these treatment options, again, because these guidelines are not set in stone. This is the study I told you about, Scott study. This is the main study that has been published last year about stem cell transplant versus Cytoxan. I don't know if any of you here had stem cell transplant, but it is a toxic. Anybody had stem cell transplant here? It sounds dangerous when you hear about it, but in that study, a lot of questions were answered actually. The stem cell transplant was useful, and it decreased all causes of mortality, but it was associated with toxicity. So it depends. I think this is a decision you need to discuss with your physician. Is it worth taking the risk, or are you better off just taking cyclophosphamide or Cellcept if you have severe disease? The same thing applies for lung disease. How do we treat pulmonary hypertension? There are many, many medications. So it's important that you see a pulmonary hypertension expert before you pick one of these medications. So screening and treatment for pulmonary hypertension is important because it's treatable. Let's go to interstitial lung disease, Cellcept, Cytoxan, stem cell transplantation. Those are the three options. Which is better? I can't tell. Now, I listed other medications because a lot of you may ask about how about the new antifibrotic drugs? How about the new drug we heard about last year that treats fibrosis? There is limited data about this medication. I listed them just for your reference, and I encourage you to go to clinicaltrials.gov to see if you qualify for any of the clinical trials listing some of those newer medications. Raynaud's, we talked about the treatment. Dr. Zachary is not here to talk about the fat transfer, but I think he has a lot of success with fat transfer. Those are his slides and the outcome before and after fat transfer. We have so many patients so far who had fat transfer, but I would tell you after a year or two, the effect goes away and you may need to do the procedure again. This is the way Dr. Zachary does it. He takes fat from around the abdomen and injects it in the fingers. And there are published reports about the safety and efficacy of this right now. Dr. Zachary is a leader in this field. This is my last slide, and I want to share this slide with you because I want you to have hope. A few years ago, we all felt that scleroderma is a deadly disease. Everybody who will get scleroderma will die. But guess what? I've been practicing in the US for 20 years, and I have patients for the last 20 years. They're doing amazing. Yes, the disease is hard. It hits your face. It changes your facial features. You may be needing to take oxygen. You may not breathing good. But we have ability to change the quality of life. And there are treatments now for the lung and for the pulmonary hypertension. There are many things you could do to improve your quality of life. Avoid toxicity, avoid toxic medications that may give you infection, because infections may kill. So how to find the balance between toxicity and safety, this is the key. This is a patient who had no insurance to be able to go and get Botox injection or fat transfer or take some of the expensive medications. I've been following him for 5 years, and you can see how his ulcers healed, his hands are doing better. I have a recent picture, his hands are doing amazing. He's able to function and use his hands. And he did not need lung transplantation. But even under the worst case scenario, if your lungs are not functioning, lung transplant is an option. Double lung transplant, patients with scleroderma do as good as patients with other interstitial lung diseases. So scleroderma should not be a reason why patients should not have lung transplant. I would conclude here and thank you all for dealing with this devastating disease, but keep the hope because there are so many things to do. And if you look at clinicaltrials.gov, there are more than 15 medications that will be in clinical trials, and there are so many medications for various manifestations of the disease. Thank you so much.